So I think, surprise, you get me for 2 drivers, if that's okay with everybody. So I'm going to go ahead and also take you through response, which is driver 3. And this was really led by Ashley and the team. Go ahead, next slide. Perfect. And, we've spoken about recognition. We've spoken about, response. And we wanted to make sure that, we struggled a bit at the beginning because we felt like there was going to be a lot of overlap in the drivers. And I think that's a good thing because we don't want people operating in silos and feel like every driver is sort of like a different task they have to do. So you'll find that a lot of these are very well integrated into each other, which we're hoping will make it a little bit easier in terms of implementation. So in terms of response, we wanted to make sure that the actual management, and this is really hitting at our first primary driver of ensuring timely treatment of severe hypertension. So we wanted to make sure the management for acute severe hypertension would happen in a timely way every time, whether you're pregnant or postpartum. So this revolved around implementing standardized protocols for treatment, which was a little bit of the borrowed from the prior HIP initiative. We wanted to ensure that trauma-informed support was there for patients and family, as we've highlighted. And then what we snuck in as something new, as Ashley mentioned, is we wanted to ensure that we had at least some role in ensuring that our patients had appropriate follow-up for postpartum after they were discharged and within 7 days of discharge. Next slide. So the standardized protocols for treatment, this is an area that I think we could do some work on. I love the fact that when we went to the kickoff, it was great to hear what other people were doing. I think that's one of my favorite things. Not only do you collaborate and you get to meet a whole bunch of great people doing great initiatives across Florida, but you also start to realize what some of the other teams are doing. And the role is really to learn from each other. So I'm really excited to sort of like be a coach and both help, but also learn from all the people doing fantastic work, knowing that each of our sort of little microsystems and hospital systems are all a little bit different. So when it comes to standardized protocol, the goal and the key word here really is interdisciplinary, whether it's, pharmacy, whether it's OB, whether it's the ER, or even EMS. We kind of want it to be expansive, but also comprehensive, and ensuring that these protocols can be implemented anytime, anywhere, and for every patient that's appropriately identified. There's a lot of excitement on nurse-driven protocols. I'm hoping that's something that makes it here to Tampa General as well, for example, for short-acting nifedipine after the first severe hypertension blood pressure is documented and then verified by the nurse. I really do think that that will help us in terms of cutting down the time for treatment. And then I think, as in everything, all of you guys have self-identified as champions for our initiative at your own hospitals, but it's important for you to now identify who the champions are going to be, who are going to help you get this initiative across the finish line at your own hospital. And love it or hate it, I'm an EHR hater on most days because I feel it creates a lot of work, but the only way to really implement things that are protocolized and standardized, we've learned and have had great success with EHR integration. Next slide. So these are excellent examples. As you guys know, there's already algorithms that are available for how we should be treating severe hypertension that come mostly from ACOG and SMFM, and these have been rolled out. These are, again, old. There's the AIM hypertension bundle, and then there's an excellent example here, and this is borrowed from CMQCC, of a perinatal safety debrief form after these events happen. Next slide. So trauma-informed care, I love this. I feel like this is interwoven into our entire initiative. This mostly surrounds making sure that we train our providers on the mental health impacts that potentially these diagnoses have on our patients, and how it also sort of carries forward with them. And I thank Mandy so much for sharing her personal experience. For us, it was like hearing it for the first time again, and I'm sure it'll feel that way forever. So thank you. We really want to ensure that we have some sort of protocol where we're assisting the patients and the families and how to deal with getting this sort of diagnosis and what that really means in the aftermath for our patients. And I think this is really a special opportunity to have and to implement things like peer-to-peer support both for us and for our patients and for each other. Next slide. These are some excellent examples. Again, the Preeclampsia Foundation has wonderful birth trauma resources, and also from FPQC. I love this. Ask yourself, am I providing trauma-informed care? It's always a nice check-in. Do you feel seen? Do you feel heard? And do you feel like you're in control? So these are fantastic, and I think great check-ins for all of us. Next slide. And last but not least, the postpartum, I think we highlighted how that is just such a vulnerable period. And being a hospital initiative, we still care about what happens after mommy and baby go home. So we have some ideas about how to sort of schedule follow-up. As Dr. Kane and Ashley mentioned, it's really within 3 days for patients with severe hypertensive disorders of pregnancy, but really within a week. We know that that has many challenges to getting patients back for office-based BP checks. So we, as other places, have tried things like telemedicine or home virtual BP, texting reminders. There's some patient portal reminders that can be sent as well. So I think just being innovative, knowing the population that you're working with, and trying to figure out what works best so that we can meet our patients maybe halfway, or help them to actually bridge that gap in the postpartum care they receive. And this is, again, another opportunity. I'm hoping everyone sits down with a patient diagnosed with a hypertensive disorder of pregnancy before they go home, just to ensure that they know what they're doing, they know what it means, they know who to contact, they have a blood pressure cuff and know how to use it, and that they're also educated on when to come back and who to call. Next slide. And these are PAC resources. I feel like I'm going with the same blue borrowed, something borrowed, something. Oh, something new. So it's okay to shamelessly steal from your own prior initiatives, because they have been just that fantastic. So here's a post-birth health check. We have a maternal discharge risk assessment. This is like, can we let this woman go? Is this safe or not? And hypertension was included in that during our PAC initiative. And a discharge assessment. And this is, again, another second check to say, is this patient ready to go home, or are there any additional resources that I should be sending them home with to keep them healthy and safe?